press got it. Good, I've got it. It's being recorded. Thank you. So good morning, and thank you very much for inviting me. I'm Tim Underwood. I'm Professor of Gastrointestinal Surgery, and I'm used to be Head of Cancer Sciences. I'm now Director of Transformation at the Medical School in Southampton. And my dog's just joined me. I'm an esophageal cancer surgeon, and we are proposing a new study in the esophageal cancer space. And I thought what I'd do is give you a background about esophageal cancer very briefly, and then explain why it's so important that we do a study like the one I'm proposing. So I will now try to share a screen with you, which will probably go wrong, but there you go. It's one of those technical things. If it doesn't work, well, I'll just talk to you. I'm sure that's equally reasonable. So if I just go to, bear with me for a second. I'll do that. And that'll ruin things because now I can't see you. Where's Zoom gone? Right. Bear with me a second. Get my IT to work again. Right, share screen. I'm going to show this one. Share. Okay, so if I now go to that, I'm going to hope that you can see a slide that has some blue boxes on it and some grey boxes, yeah?
Yes, can do.
Excellent. Okay, so what I'm showing you here is the treatment algorithm for esophageal adenocarcinoma. That's what OAC means on the left. And this is for patients who have potentially curable esophageal cancer. The reality of my disease type that I look after is that unfortunately, only about a third of patients are suitable for treatment with curative intent at the time of diagnosis. 2/3 of patients we see have already got a cancer that's spread too far locally, so into the local organs in the lungs or the heart or the aorta, or has got metastases, secondary deposits elsewhere in the body, and we can't think about a cure. So I unfortunately only see what we might think about the lucky 1/3, but actually when you look at what they have to go through, it's far from lucky. The reality is that these people have really intensive treatment. They are put through preoperative chemotherapy, which is the top one here, or preoperative chemoradiotherapy, then have an operation, the thing that I do, which takes 5.5 hours. They stay in hospital for about 10 days, takes 6 to 9 months to recover from at best, and they're left with lifelong symptoms. And after all of that, unfortunately, 5-year survival at best is 50%. I mean, you look down here, this is associated with 2% mortality from the chemotherapy and 2% mortality from the surgery. So we put people at significant risk in an attempt to cure them, but we don't succeed well, we'd like to succeed in far more than we do. So it's worth understanding how effective this chemotherapy might or might not be and how we could improve that. And the first thing we can do is improve it by predicting things better, and we can use better data. So we know that survival is variable and is patient dependent, and not all patients are the same. And the current staging systems we use don't capture that individual patient's survival very well. They group patients coarsely, but they ignore important variables like whether or not there was any cancer cells left at the end of the operation, for example. That's not recorded in the standard TNM staging. Patient comorbidity isn't recorded. There are lots of things that are important for outcome. So we've done a bit of work to make that better. Oops. And if you look at these two patients here, this captures the problem, one of the problems that we have. Both of these patients would be deemed to have a stage 3B cancer, and you would predict their outcomes to be similar. But if you look at them, the patient on the left is a 60-year-old female, completed chemotherapy, had one lymph node involved, and the CRM is the circumferential resection margin. So the surgeon was able to take it out and the margin was negative. There was no cancer cells left. They're given stage 3B. This patient on the right here, this 61-year-old male, didn't complete their chemoradiotherapy, had 4 nodes rather than 1 node involved, and there they had some residual cells left. Now you would expect intuitively, just by looking at that you think the man would do worse than the female. Yeah, it's pretty clear that there's reasons why that might be the case. But the prediction from TNM, the current staging system, will be exactly the same for this pair of patients, which is clearly not right. So we did a load of work using the national audit data set. Which contains all the oesophagectomies done from 2012 onwards, and we looked at an original sample size of nearly 14,000 patients, got to a final sample size of nearly 7,000 for our bit of work here. And we used some machine learning technology to try to give a really detailed and personalized prediction of outcome. And we use something called random survival forests, which are decision trees like the one on the right here. The detail isn't necessarily that important, but what it says is it makes a decision at each point, accepting and using a variety of variables, and that can model interaction between variables in an individual patient rather than giving them an overall score that's the same for each patient, because a variable may be different in an individual patient, man versus woman, age, that sort of thing. And these are the variables that we modeled it on. There's a lot. That's a lot more than we use in TNM. And the pie chart on the right shows the importance of the variable. And you'll see that the number of lymph nodes is the most important variable, bar none. And all clinicians would tell you that. But every other variable there is important for prediction of outcome. And what you get then is you get a range of predicted outcomes where you have blue is the standard prediction you'd get from the currently used TNM stage. Green is a better prediction for individual patient, and red is a worse prediction. And you can see for these stage 3B patients here, you get a wide variety of predictions, so that some patients do far worse, some patients do far better. And that's really important, because even if you don't think about changing the treatment, the conversation that you might have with that patient in clinic after their operation is very, very different. You can imagine the conversation you have with this patient, who's very likely to survive, is very different from the conversation you have with this patient, who we would predict would have recurrence of their cancer. They need to know about that. They need to understand how to change, potentially make decisions in their life that are important for them as an individual. And these are the 2 patients I showed you at the beginning. That's the lady on the left and the man on the right. And as we predicted, the person on the right is going to do far, far worse. Their predicted survival is 5 times worse than the patient on the left. So why am I driving at this? Well, it's important that we understand how to predict outcome, but it's also important that we can think about ways to improve outcomes for patients like this and for patients like this. And how are we going to go about doing that? Well, the first thing to understand, and I'm going to click through here, is that not everyone benefits from the neoadjuvant therapy that we give them. Yet we give it to nearly everyone that we see because it's the best treatment that we have and it's proven in the best studies. So this is what we're talking about, the preoperative treatment with chemotherapy or chemoradiotherapy. And for today, we're going to stick with chemotherapy because that's the predominant therapy given in the United Kingdom. In Southampton, we give quite a lot of chemoradiotherapy, but if you look at the national audit data, 95% or more of patients are given chemotherapy alone and then have their operation. And we know from the biggest studies that if you give chemotherapy, it has a survival advantage over surgery alone. And you know what I've done? I've made an assumption that you all understand what these Kaplan-Meier curves are, but I'll explain it so that those of you that may not. On the y-axis is survival, and that's you can 1 to 0, or you can think of it as 100% survival and 0% survival, and time along here. And every step on these curves actually represents a real patient's death. I'm never immune to that every step on them, we'll talk about these curves, and I talk about them in terms of big numbers, but every individual is a step, is an individual death on here. And the quicker that this goes down, the worse the overall survival for that particular treatment is. So you can see there's a separation in these curves here, so that at 5 years here, surgery alone in this study you saw about a 25% survival, where you were approaching 40% when you added the chemotherapy. So chemotherapy made a difference. But it made a difference, not for everyone in a tiny increment, but for some massively, and for most, not at all. And we can grade how well it works when we look at the specimen that we take out at the operation down the microscope. And we grade tumor regression, it's called, so the cancer, how it's affected by the chemotherapy, and we grade it on a 5-point scale. TRG1 being the best, no cancer is left in the specimen at the end. TRG5 being worse, there are absence of regressive changes. The chemotherapy hasn't worked. Someone has a question, go for it. Far away, someone's hands up. You're muted, I think.
Hi, Tim.
Hi.
I was just going to ask you, a few slides ago, you said that you have a discussion with the patients. Now, what would that look like?
It's been early days with this model, but I actually asked patients whether they wanted the detail of their predicted survival. And most of them say yes, and then I show them and I talk them through what it means, and I talk them through that this is a predictive model. It's not absolutely 100% accurate, but it's the best that we've currently got. And then that conversation is led by the patient, really. If it's a very good survival, they're clearly very pleased and they think, well, that's wonderful. If it's a very poor survival, it can be around, okay, this is only a prediction. It's not actually, it's not guaranteed to happen, but the reality is if we took 100 patients like you, this would be the likely outcome. So we need to think about things now around your planning for what you want to do for your future. If it's predicting a low chance of survival at 2 years, do you want to think about getting all the things done you want to while you're fit and healthy now? They're young, recording voice, recording videos so that their relatives will have them if and when they die. It's thinking about really giving people the opportunity to consider a good death after having a good life. That may sound a bit weird, but I think that's really important. We don't necessarily talk about that enough in our society, and it's really important to me. It's one of the things that we can really help people with.
Yeah, thank you very much. Yeah, it does make sense. And apologies for, I thought I could just raise my hand and talk to you after the
Oh, you can raise your hand and ask. I don't mind being interrupted. It's perfect. It's better to go as we go along. I have no problem whatsoever. Absolutely fine. So I was talking about tumor regression grades, right? So you get the idea. 1 is good, 5 is bad. Okay. So we looked at a big cohort of patients where we then said, who gets a survival advantage from the chemotherapy? And actually, you can see by this figure here, we published this in the British Journal of Surgery. The survival advantage is very much confined to those patients who have a TRG 1 and 2 only, not a TRG 3 to 5. And unfortunately, that's only about 15 to 20% of the population that we treat. So we're giving 80% of patients chemotherapy that is toxic and has unpleasant side effects, and it has little or no benefit to them. But we cannot predict who it will be. Okay. So the idea of the trial is to try to improve this. And what I'm going to do now is stop this one and show you some data about PDE5 inhibitors that we are preparing to use. Now, does anyone know what a PDE5 inhibitor is? Why would you? A PDE5 inhibitor is the class of drug that includes Viagra. So it's Viagra and other that's called sildenafil, and we're using a drug called vardenafil, which is a sister drug to Viagra. And these drugs, as you may or may not know, were initially discovered they were initially made as cardiac drugs for chest pain and cardiac treatment, but they were found to be vasodilating drugs, and they are used around the world in billions of doses for erectile dysfunction. Amongst other things, they're also used to treat pulmonary hypertension, and they're used to treat fibrosis. And they're used to treat those drugs, those conditions, not necessarily because of their vasodilating effect, but they're used because they change the behavior of a cell type called a fibroblast. And a fibroblast is a cell that is in every tissue in the body and creates the scaffold from which your tissues exist. So if you cut your finger today, if you cut yourself, the first cells that react to that, one of the first cells that react to that are the fibroblasts. They become activated and they take on a smooth muscle-like, so a muscle-like phenotype. They become more muscle-like. They go into the middle of the wound and they stretch out to the sides of the wound and they make collagen, which is the matrix that makes the body, and they pull the sides of the wound together so that the skin cells can grow over the top. So fibroblasts are really important. They're really important in wound healing. They're really important in fibrosis and chronic conditions of overactive wound healing. And they are also corrupted by cancer cells and changed into an activated cell type, like a chronically healing wound. And cancers are very much described as chronically healing wounds. But the cancer cells make the fibroblasts become activated. So they corrupt them to their own end. We've discovered that if you give PDE5 inhibitors, Viagra and its analogues, to cancer cells and to cancers and to the fibroblasts, that they revert the activated fibroblast phenotype. So they can interrupt the corruption that the cancers produce in the fibroblasts. Everyone with me so far? Does that make sense? I'm explaining it hopefully clearly enough, because then I might show you a little bit of data, and that data is relatively, I'll show you some cell stuff. I've got to just stop this. Bear with me again for a second. Right, I'm going to show you something different. And I'll be very brief because I know I'll be over time and you want to talk to me. So if I show you a couple of slides that up there, a couple of figures that we've made from the data that we've got. The first one, if I'm going to share my screen again, I'm going to show you that one. Right. Can you see some graphs there? Is that coming across? Yeah. Okay. Perfect. So what we're showing you here is that we looked at whether or not there is an excess of PDE5 in esophageal cancer, and there is. This is esophageal cancer here, if you can see my cursor, and this is normal squamous epithelium. There is more PDE5 expressed in esophageal cancer than there is in the normal esophagus. And if you look down here at D, we've then said, if you look at survival from esophageal cancer based on the expression of PDE5, is there a difference? Well, there is. If you have high PDE5, survival is much worse than if you have low expression of PDE5. So this is important. The expression of this enzyme is important for survival in esophageal cancer. And hopefully this will work, and I can show you a couple more figures. We've done then lots of molecular biology, and this is all about in-lab stuff where we've taken out fibroblasts from esophageal cancer and we've treated them with PDE5, and we've looked at their phenotype, what they do, and we've been able to show that you can revert the activated phenotype. And I'll show you that more clearly in a better figure. This is a better figure. So if you look down at just the E here, this captures the data. What we've done here is made artificial cancers in the laboratory, and we've included fibroblasts in these cancer models. And on the left, you can see that this is the cancer on the top here. This is the stroma, or the scaffold cell, scaffolding of the tissue, and the cancer is invading into it. When we treat that with a PDE5 inhibitor, because we affect the fibroblasts underneath, we completely abolish the invasion of the cancer into the tissue. That's pretty clear, I think, from that. You can see there's cancer cells coming down here. There's no cancer cells coming down here. And further to that, we've moved on and used a mouse model. Let me find the right one. We did some proteomics. We did some single cell experiments to prove the point, but we've also used a mouse model, and we've used something called a tumor growth assay, which is a close to patient assay. And if you look at these over here, what we've done is taken out a cancer from a patient at their diagnosis, and we've grown it with fibroblasts, and we've treated it with standard chemotherapy that we would use, and it's an equivalent dose to what we'd use in humans. And if you look at here, the red shows where we would predict non-response because we weren't getting good enough killing by the chemotherapy. When you then do exactly the same thing, but you add a PDE5 inhibitor, you can see that for the large number of these, we've now converted them from red to either amber or green, which means there is a response to the chemotherapy and there is cell death because we've added the PDE5 inhibitor. That's all in the laboratory, and that's all not in humans. Someone's got the hand up. Go for it. You're muted again. It's the old mute button. Are you with us? No. Save it up for later or put it on the text and I'll answer it in a minute. And we've done a similar thing with a mouse model. And in the mouse model, we've these are two markers of the activated fibroblast phenotype. This is periostin, this is alpha SMA. It doesn't really matter what they are, but there are markers of this activated fibroblast. This is untreated here. And the brown stuff is staining for this. When we treat with vardenafil, we get rid of it. And the same down here. And what we've also shown is that the tumors don't grow as fast in the mice when we give them vardenafil. So we have good preliminary data that we think that PDE5 inhibitors are worth testing in human beings. So our study now is that we propose is to do a phase 1b, phase 2 study where we test whether it is safe and tolerable to add PDE5 to standard of care chemotherapy initially in the advanced disease setting, and then see whether there is efficacy in the pre-surgery setting. So we're going to give people their chemotherapy. We're going to add quite a large dose of a PDE5 inhibitor because they're safe and effective. We're safe, sorry. And we don't think we'll have additional side effects, but we'll test that. And we'll see whether or not that has an effect on the response of the tumor to the chemotherapy. So we're trying to add to the benefit of chemotherapy by directly targeting the fibroblasts in the cancer. And that's the plan. And I'll stop there because it's probably enough, but hopefully I've given you a whistle-stop tour of some lab data and some clinical data that adds up to something interesting, I hope.